Hey everybody, welcome back to the ECG of the day. My name is Reed. Don't forget that you can download this PDF of this document down in the description below and follow along. Make your own notes, keep it for later. And please consider liking this video and subscribing to the channel if you really enjoy this content so we can keep putting things out there. So let's get started. So first thing I'm going to do is look at the forest, and the trees of the forest are my QRS complexes. And so maybe I'll start down here at lead 2. I see I've got this borderline kind of bizarre looking rhythm, but it's pretty regular whenever it does exist. I would say it is narrow, right? QRS seems to be within normal limits, which is less than 120 milliseconds for my QRS duration. Seems to be regular, but we've got these funny looking beats right here and right here and right here at the end. So we've got some funky beats throughout. The rate here will say, if I find a QRS that lands on this solid line here, and we'll count backwards, a rate could be 300, 150, 100, 75, 60. This would be 50, so maybe 58 beats per minute. So we have a little bit of a bradycardia. And you can see here, if you look in front of my QRSs, we do have sinus, or P waves at least. We don't know if they're sinus yet. So I would say this is likely some type of atrial bradycardia. So let's evaluate those P waves. The P waves are upright in lead 1. They are upright in AVF. It tells me that they're going down and to the left, which is common if they're originating from the high right atrium SA node. So these are sinus P waves. And so I scan throughout and I see that most of my P waves, all of them, are this nice sinus P waves. This is likely a sinus bradycardia, but before we can really say it, let's evaluate our PR intervals. Really what I'm saying is let's evaluate the AV node, right? Make sure that every P connects to a QRS. My PR interval, if you look here, my PR interval looks to be about 160 milliseconds, which is normal, in between 120 and 200 milliseconds. And as I scan throughout, I see that my PR intervals stay the same throughout the entirety of the strip. And I don't see any P waves in the middle of these that don't conduct to QRSs, right? So that is a normal AV node function. The QRS itself, let's evaluate that. My QRS complexes are upright in lead 1. They are upright in AVF. So that tells me that my axis of my QRS is down and to the left, and so that's normal axis. That makes me happy. And my R wave seems to progress nicely. We got a little septal R wave that grows in here, transitions at V3, and then we have nice positive QRSs through the lateral aspect of the precordium. And my QT interval looks to be appropriate. I like to maybe pick an R to R and make sure my QT lands at least by the midway point of the R to R, which it does. And so the last thing I'll do with this rhythm is we'll look for pathological Q waves and ST and T wave changes throughout this rhythm. And what I notice is I've got these, first I don't see any ST elevations or depressions that make me think of acute ischemia or infarction. But if you look here in the inferior leads, really leads 3 in AVF, you can see these pathological Q waves, these deep Q waves here, that deep Q wave. And in AVF, you can see a little Q wave there. And so those are pathological Q waves, really predominantly. You can see a little bit of it there in lead 2, but predominantly in leads 3 in AVF. Right? So somewhere in this aspect of the myocardium, there was a previous inferior MI. So we've got a previous inferior MI. And I don't see any other acute ST or T wave changes. So now let's look at these funky beats, right? These funky beats, if you look at them, they appear to be wider than my normal QRS, right? So they have widened, so they are a little bit more wide. They don't really come incredibly premature in any sense, right? They're almost on time. And so this makes me think, are these ventricular? So really, are these ventricular ectopic beats because they're wide? Or are they atrial beats that conduct aberrantly through the ventricles, some type of block. And the first thing I notice is that here, maybe if I look at this beat that's funky, you can see the P wave right there. So I see a P wave, and that's my nice normal sinus P wave. But that P wave conducts to this QRS with an incredibly short PR interval. That PR interval is much shorter than what we measured the PR interval at, right? We said it was normally 160 milliseconds. This PR interval looks to be maybe 100 milliseconds or so. The AV node doesn't just get better. So what I think is actually going on is we're having a ventricular ectopic beat that's occurring right before that sinus P wave conducts to the ventricles, right? So what's happening is we're getting our sinus node is firing off, and it creates that nice atrial P wave that we all know and love. The AV node captures that signal, and right before it's about to send it down, you get some ventricular ectopic beat that depolarizes the ventricles and cancels out that signal and doesn't allow for that signal to come down. And so I think that's what's happening. Actually, I know that's what's happening here. There would be no other explanation for why the PR interval got so short. And you can see that occur here as well, right? You can see the beginning of that sinus P wave just right there. You can see the beginning of it, but then we have this ventricular ectopic beat that occurs right before that P wave can conduct down to the ventricles. And the same thing happens here, where we have, look at it, we had our normal sinus P wave, P wave. We would expect our next P wave to be right there, which we see it, but we have this ventricular contraction that occurs right before it can conduct down to the ventricles, and so it doesn't allow it to do that. And so I would say these are ventricular ectopic beats. You could say they're premature. Technically, they are premature. They're occurring before we're getting ventricular conduction. But at the end of the day, it doesn't really matter. We just need to know what it is and why it's occurring. And that occurs throughout this strip 3 different times. And so let's put this all together. And what do we have? We have a sinus bradycardia at a rate of 58 beats per minute. We have evidence of a previous inferior MI with pathological Q waves in leads 3 and AVF. And we have ventricular ectopic beats that occur throughout the strip in 3 different locations. So you could probably say with ventricular ectopy. And so if these ventricular ectopic beats were concerning in any way, if this person was having episodes of ventricular tachycardia, you could be concerned, right? Think of, we've got this previous inferior myocardial infarction that we said occurred somewhere maybe here. And if you look at this PVC, it's got negative forces in the inferior leads, right? Lead 3 and lead 2, it's negative. So these PVCs, or these ventricular ectopic beats, are going away from these leads. So that means that it's traveling up from the inferior portion. So what you don't want, what you want to be really cautious about, is if the scar tissue that was formed by this previous MI, this is pro-arrhythmic. These are very pro-arrhythmic. And so what you don't want to happen is to someone have a focus in that scar tissue that could be firing off these ventricular ectopic beats, and that if they get too hyperexcited, it could, create a ventricular tachyarrhythmia, and that would be, potentially lethal. So I would correlate these ventricular ectopic beats clinically, and really be cautious when you see somebody with a previous MI with ectopic beats that look like they could be arising from that region. So I hope this helps you kind of put everything together with this strip. It's not always just these benign occurrences, right? We need to correlate them to the anatomy and to what the risks of future adverse events are. And so I hope this helps. If you have any questions about this strip, throw them down to the comments. And if not, thank you so much for watching. And I'll see you on the next ECG. Take care.